My name is Brandon Warren, and I will be presenting a case report entitled Another Two-Hit Hypothesis. Heparin-induced thrombocytopenia, or HIT, is a potentially life-threatening complication that results from the development of heparin antibodies to platelet factor 4, or PF4. Subsequent platelet activation and potential for life-threatening thrombosis if left untreated. In this case report, we will examine the causes of thrombocytopenia and diagnosis of HIT and the subsequent management. In this case, we present a 70-year-old female with a past medical history of heart failure with preserved ejection fraction, atrial fibrillation, hypertension, mild mitral stenosis, insulin-dependent diabetes mellitus, chronic kidney disease, and hyperthyroidism, who presented to the emergency department for arrhythmia secondary to complete heart block and hyperkalemia with a potassium level of 7.3 millimolars per liter. Nephrology was consulted for hyperkalemia and acute renal failure management, requiring treatment with continuous renal replacement therapy, or CRRT. The patient was also started anticoagulation with intravenous heparin for stroke prophylaxis. On the second day of admission, the patient's platelet count decreased from 277,000 per millimeters cubed to 193,000 per millimeter cubed. Heparin was continued as thrombocytopenia was attributed to the CRRT, which is commonly associated with a significant reduction in platelets. Renal replacement therapy was continued until resolution of hyperkalemia on day 6 of admission, with a platelet count of 43,000 per millimeter cubed. 2 days after discontinuation of the CRRT, on day 8 of admission, the patient's platelet count remained low at 66,000 per millimeter cubed. Heparin was stopped due to concern for HIT. HIT workup was started this time with initiation of agatroban, and orders were placed for platelet factor 4, or PF4, and serotonin release assays, or SRA, testing. After 5 days of agatroban therapy, the platelet count had improved to 265,000 per millimeter cubed on hospital day 13. Initial HIT testing revealed a positive PF4 and negative SRA values. Given the strong negative predictive value of SRA testing, argatroban was discontinued and heparin restarted the following day. The platelet count subsequently decreased within 24 hours of rechallenge with intravenous heparin, and the patient experienced abdominal pain, which was concerning for potential mesenteric thrombosis. A repeat SRA test was ordered, which resulted positively. Heparin was again discontinued, and argatroban was restarted. Thrombocytopenia and abdominal pain then resolved, and platelet count increased to 287,000 per millimeter cubed by hospital day 27. Investigation of discrepant SRA results was initiated. The patient was discharged home on warfarin for management of her arrhythmia and likely HIT. To recap, this is a 70-year-old woman who is treated with heparin for atrial fibrillation and CRRT for hyperkalemia and an AKI. Her initial SRA was negative, although her platelet factor 4 was positive. Subsequent rechallenge with heparin after initial discontinuation showed a positive SRA on repeat lab testing. We initially suspected CRRT as the patient's cause of thrombocytopenia, after the SRA resulted negative originally. However, it was ruled out after the patient began to show signs of worsening thrombocytopenia when rechallenged with heparin, leading to the official diagnosis of HIT. This case illustrates the need for careful clinical examination and evaluation of lab values and test results. Because there are multiple medical and procedural, as well as physiologic causes of thrombocytopenia, a thorough review of the patient's medical diagnosis and treatment plan were performed to evaluate for all potential causes. Other medications that can lead to false negative SRA tests include Brilinta, which the patient did not receive. This interesting case demonstrates the importance of pairing clinical judgment with lab results in establishing a diagnosis.